Ralph Muller.
Well, thank you. It's a pleasure to be here, and I know there's a lot of Penn people in the audience, so I'm not going to talk that much about Penn today. I'll give you maybe a slide or so at the end. But given the centrality in the last few years and the kind of partisan debates in Washington and elsewhere about health care and Obamacare, which is, even the president now calls the Affordable Care Act Obamacare, I thought it might be helpful for me to kind of just talk a little bit about how health care is being structured inside this country. As you start thinking about who you're going to vote for in the next election, what's going to happen in the Senate and the Congress and the presidential race, you still see, even in the debates that started last week on Fox News, the usual call for the Republican candidates to get rid of Obamacare. You'll see my bias is that Obamacare is a good thing. I'll try to explain to you why, but I thought it would be helpful, and especially a lot of you, as I heard you get up, a lot of you have been inside HR parts of the enterprise, and many big corporations, Comcast, et cetera, and so forth. The HR people run a lot of the benefit plans. They've had to make a lot of choices the last 4 or 5 years. Obamacare really changed the landscape nationally in terms of how healthcare is structured. So if you bear with me, and hopefully it's not too academic, but it's part about being at Penn, but I'll try to just give you a little overview of what's really happening in this incredible tumult that's going on in the healthcare arena. And I'll do a little blurb for Penn at the end, as we are proud of the fact to be one of the great health systems inside this country. As I was saying to Ann, who was sitting at the table, we've made, I think, an enormous difference. One thing I really paid attention to when I got there is how to pay attention to patients, to be much more patient-oriented, and I think it comes through, hopefully, as you experience us. So let me give you a little run-through. Thank you. So I'm going to talk a few things here. Pardon me, it's not in front of me. The Medicaid expansion, health exchanges, what's happening to outpatient care, some jargon about value-based care. Now talk a little bit about the local environment, the kind of disruptors, and what's going to happen, I think, in the future. Though, as Yogi Berra often said, it's hard to make predictions, especially about the future. So one thing that's happened with Obamacare is an enormous expansion of the uninsured. I'll show you a slide in a moment. The estimates are about 15 to 17 million people more insured inside the country. And a lot of that happened with what's called the Medicaid program. The Medicaid program is the program for the poor, though Obamacare has expanded that so that people roughly up to about $35,000 of income can get eligibility for Medicaid. Fortunately for Pennsylvania, until the new governor came in this past January 1st, there was not a Medicaid expansion in Pennsylvania, so we did not have the benefit of a lot of Obamacare for the first 4 years of it. When Obamacare was first passed in 2009, 2010, there were about 50 million people uninsured. And the intent was to bring that number of 50 million down by about 30. That is, increased about 30. They're about halfway there. And part of the reason I'll point out in a moment, they're only halfway there. Many states, I'll call them the red states, since they call themselves the red states, the governors like in Florida and Texas and so forth have chosen not to expand the program, which has a real consequence for the citizens living there because they don't have the benefit of the expansion. But part of Obamacare, since all of you who buy health care in big corporations, or even when we buy health care, are concerned about the cost. As you know, up to the last 3-4 years, healthcare costs were going up 2-3 times the rate of increase of the consumer price index. Fortunately, the last 4 years, the rate of increase has been more like 4%. So still 4 is not the consumer price index, but it's not 9 or 10 anymore. So it's been the biggest abatement of cost increases in the last 40 years. There's some evidence in the last year it's starting to heat up again. So a lot of focus in Obamacare on how much we pay for healthcare. So themes so far, let's expand the number of people who are covered, because when you're not covered for healthcare and you get sick, real bad things happen. Secondly, how do you cover costs? And also, how do you reorganize healthcare? There's a jargon about in healthcare, it's called fee-for-service healthcare or volume-based care. The more a doctor does, the more he or she gets paid. And they're trying to move the system towards you kind of get paid in advance. I use the example, like if you take a cab from the airport to downtown, there's a flat rate, $28.50 or so to downtown, versus I know a lot of anxiety people have, especially when you're younger, don't have money and so forth. You get in a cab from the airport and especially since I grew up in New York, you never know how many boroughs they take you through by the time you got there, if you were new. So all of a sudden, and what they're trying to do in healthcare right now is to go to a flat rate, as opposed to saying let the taxi meter run as the taxi goes through 5 boroughs. So that's essentially, in a simple way, we're going from letting the taxi meter run to having a flat rate. That's what they're trying to change. Now, I talked about the Medicaid expansion. You can see the states in the yellow or gold did not expand. Looks a little bit like the red state, blue state divide, in case you follow politics inside this country. And especially since Texas and Florida are 2 of the 4 largest states right now, the lack of expansion there just meant that the promise of expanding healthcare inside this country has not been met. I would argue this is more for ideological reasons than practical reasons. They'd be better off, especially since you and I as taxpayers are paying for the Medicaid expansion. So right now, if Florida or Texas and these other states in the yellow or gold expanded, we'd be paying for it. So basically, we're paying for it, and they're not getting the benefits. So they're not being very prudent, if nothing else. This is a chart, a kind of heat map of who gained insurance from the Affordable Care Act. And the darker colors means more expansion. You'll notice Pennsylvania is very light. We have not expanded very much until this calendar year. The expansion in Pennsylvania only really started in the last 6-7 months. So in some ways, unfortunately for us as taxpayers, you and I were paying for this expansion around the country. So you notice California, Nevada, they're all nice and red, and Michigan is nice and red, and New Mexico, your tax dollars were paying for them to expand while we didn't expand. I think I prefer the expansion in Pennsylvania, but I was regretting the previous 4 years when the previous governor would not expand it in this state. And essentially, these numbers are hard to read. The estimates of how many people have gotten insurance, 13 to 15 million, and about 550,000 in Pennsylvania. So roughly about 60% of the people eligible have gotten it so far, which is, as you can tell, not 100%. So a lot of room for people to sign up for health care. And they now, under Obamacare, they borrowed the nomenclature from the Olympics. They're called medal plans: platinum, bronze, silver, gold medal, as you get your medals in the Olympics. And this chart just tells you 2 things easily. In the last 5 years, and HR people in this room know, the amount of payment you as an employee make towards your health care has gone up. And the chart on the left basically says 5 years ago, 80% of the people paid $1,000 or less. Now it's down to 60%. And the people who are paying $2,000 or more has gone from 7 to 18%. A lot of the jargon on this is called consumer-directed health plan. It's a euphemism for you pay. And all the plans are now doing it. And under Obamacare, about 2/3 of the people signed up for the silver plan, as you can see there. Now, a lot of you have heard, I'm sure if you hung around social scientists in the last couple of years, about the influence of something called behavioral economics and how people are thinking about the world. And what behavioral economists have told us, most people buy health care based on the monthly deduction from their paycheck. And if you know now, if you go to a doctor these days, you pay a little bit copay, you pay a deductible, as the chart on the left shows. If you were a reasonably rational person, you'd say, it's not just that I'm paying $80 a month. If I'm going to pay $20 for my copay for my medicine at CVS, and I'm going to pay 20% copay if I have an MRI or a colonoscopy and so forth, you think people could do this calculation. Well, no, even the faculty at Penn can't do this calculation. So most people do the simple thing, which is I look at my monthly premium and I buy that plan. Well, you'd be better off, the economists say, can you do a calculation as to what you're going to pay? So you want to calculate not just your monthly premium, but your copay and your deductible. And all of a sudden you find out it's not $80 a month, but it really averages like $200, $300 a month. But most people still choose the wrong plan. I think next time around, they'd be better off going to a plan, especially if any kind of disease, you should go to the gold plan out of the silver plan and kind of average your payments over the course of the year. Now again, this is more technical than you want to hear, but a lot of people, the leading cause of bankruptcy right now in the country is high medical costs. So if you pick the wrong plan, especially as employers are increasingly trying to have you as a patient, as a consumer, pay more of the costs, if you pick the wrong plan, you're going to be paying more out of pocket. So something to be very careful about. And What's also happening, I'll do a little bit of blurb about us. We have big outpatient centers. Some of you have been to the Perlman Center, which is right next to our big hospital hub. But we have a big, enormous building called Penn Medicine Washington Square at 8th and Walnut. That's a 20-story outpatient tower. For those who also know West Philly, we have a 12-story outpatient center called Penn Medicine University City. We have a big one in Radnor, a big one in Valley Forge. We just opened one in Jennersville. We're in Cherry Hill, we're in Woodbury, we're in Bucks County, and more to come as we expand. 55% of our activity now and our dollars come from outpatient care. The world has moved to outpatient care. When I first came in this field, when I was the president of the University of Chicago Hospitals, when people needed chemotherapy, let's say for breast cancer or prostate cancer, they came to the hospital for 10 to 14 days. Now they come to the Perlman building for 4 hours. So all the patients that came to hospitals 25 years ago for chemotherapy now do it on an outpatient basis. The world has moved to outpatient care. So you see here, outpatient, much more outpatient, inpatient admissions are going down, and certain procedures are also going down as part of outpatient. If you're a national employer, like Alexander sitting next to me works for Comcast, if you're running HR benefits for Comcast, and you say to yourself, I'm a national company, I have employees in San Francisco and in Philadelphia, and there's 30% more use of hospitalization in Philadelphia than in San Francisco. Now, some of that is, we eat cheesesteaks and they eat tofu. But by and large, if you're the HR consultant there, you say, why am I paying for 30% more hospitalization in Philadelphia? And why can't I get hospitalization down in Philadelphia the way it is in Sacramento or Portland or Tucson? And what's happening, these national companies, with the kind of globalization of all our companies, all the big banks are national companies, and Comcast is a national company, and Merck and Pfizer, et cetera, and so forth. All of them are saying, we want to get to the same ratios that we see in Tucson or Boulder, Colorado, and so forth. Now, all of you who've traveled around the country know, a snowboarder in Boulder looks a little different than people at our airports. But by and large, a lot of it has to do with underlying health conditions, but they're all driving us to bring down inpatient admissions. That's a national trend. And the highest hospitalization rates in the country are in the Boston to Baltimore corridor. So you can probably, most of that is lifestyle, but a lot of it has to do also. And the lowest ones are in the Southwest and up in Wisconsin. As Garrison Keillor says, all those Lutheran farmers don't go to the doctor. So you basically see with the Northeast corridor largely being the place where there's highest hospitalizations. So when I talk to Blue Cross, which is the biggest insurer in town here, and we're good friends with them, but they constantly say, we have to get the rates down to compete. You may have noticed Aetna is buying Cigna, and a big company called Anthem is, I lost track of the buying. The big consolidation going on in insurance companies. So at Blue Cross, for them to compete, they have to be able to get the hospitalization rates down in Philadelphia. Otherwise, they can't sell the national contracts vis-a-vis Aetna and United and Anthem. So that's this is basically this is a fancy way of saying I want to take a taxi ride for $28 rather than having to meet a ride. So Medicare essentially said by 2018 they'd try to get most of Medicare payments 50 to 80% basically on a flat rate, as opposed to having what's called fee-for-service medicine. Now, over the last few years, hospitals are being evaluated on, some people know that people get sick in hospitals. You can get infections in hospitals. Some people know that sometimes you come out of a hospital, you get readmitted. So in the last couple of years, as part of Obamacare, all the hospitals, the 5,000 hospitals in the country, have now been penalized if either our rate of infection or our rate of readmission is higher than some national norm. And it shows you, these charts basically tell you that 3 to 5% of the revenue we get is now at risk if our infection rates are too high or readmissions are too high. Fortunately for Penn, we do very well on these things. We've worked very hard on that, so we don't get penalized, but up to 5% is at risk if you don't. So again, this is part of that whole shift. I talked about getting a taxi ride to be on a flat rate in the meter. There's also now an effort, don't get sick in a hospital, get better in a hospital, and we'll penalize you if your hospital has too many readmissions and too many infections. And as you can see here, in the last year, 2014, basically 1,500 hospitals were penalized. And since on some of these policies, you win some and some you lose some, a lot of times it gets pretty close to a wash. But the average penalty in this case was only about 1/4%. But it could by 2018 get up to 4 or 5%. And this is just another version of what I mentioned to you earlier in terms of how to move from what I call the taximeter to the flat rate. The technical jargon for the taximeter payment, which is when you see a doctor, when you get a test, when you go to hospital, you pay a fee. That's called fee for service, and that was rationalized in 1983 into something called prospective payment system. We've had some, over the last few years, Blue Cross in our neighborhood and other insurers around the country have been, quote unquote, paying us for performance. So, for example, if we keep readmissions down, if we keep infection rates down, Blue Cross now gives us about $8-10 million a year because we do well on that. In the last year, when you go to one of our hospitals, what we get paid for the hospital service and the doctor service is now called bundled together. It used to be you pay the doctor, you pay the hospital, now it's one bundle for cardiac and orthopedic procedures. And increasing now, we're moving towards something called episodes and shared savings. These aren't terms you have to know, but essentially what they're asking us to do is take care, let's say, of breast cancer for the next year. Instead of you go see Dr. Chow for breast cancer and you see radiotherapy afterwards, and maybe you have an imaging study, and maybe you have a follow-up outpatient test, and maybe, depending, you need some rehab because your arms aren't as strong. So instead of saying each of those is a separate bill, we'll pay you for breast cancer for the year, and you, Penn, take the risk of doing that. So they're moving us in that kind of direction. And the fullest example of that is something called capitation. A lot of this in California. Any of you here live in California, ever use Kaiser out there? But Kaiser is the big health system out in California and Oregon. And basically, they're an insurance company as well as a set of doctors and hospitals. So with Kaiser, you pay $7,000 a year. They're an insurance company. And for $7,000, you get your health care. And they'll take the chance that you're 30 years old and you won't see a doctor, and they pay zero. They'll take the chance you need a liver transplant. It's going to cost $150,000. So they basically take what's called the actuarial risk. So they are insurance companies as well as a set of doctors. Now, you can only go to a Kaiser doctor. They don't want you going all over. They want to socialize the doctors in the right way and put them in the right information system. That's the model. They've been trying to move the rest of the country towards this model for 30, 40 years. The fact that it hasn't spread much beyond the southwestern California and has not penetrated Pennsylvania as well is an indication that this is not that easy to do. You have to own the insurance company, you have to own the hospitals, you have to own the doctors, you have to have the information systems. You have to socialize the doctors to be this kind of doctor rather than other kind of doctor. It's very hard to take some doctors who've been practicing one way for 30 years and kind of convert them to a Kaiser doc. So they basically grow their own, just like the church does and the Marines, they grow their own. So these are just some examples of these kind of bundles. This is a little too technical for you, but essentially there's a lot of variation around the country in terms of how well. So all of us are learning. A lot of data, big data has come to healthcare, and you can see basically the point on the right is there's an enormous variation between quote-unquote low-cost hospitals and high-cost hospitals. If when you leave, if you have a knee replacement at Penn, do we send you to home with a lot of rehab before you go home? Do we make sure you follow that rehab? Do we send you to a rehab facility? Do we send you to a nursing home? An enormous difference in cost if you go to a nursing home versus you go to a rehab facility, whether we can take care of you at home. So we're getting incentivized to make sure through information technology and so forth. We have a great example going on now for people with heart attacks. You would think after you have a heart attack, pretty serious wake-up call, right? When you take your medications after a heart attack to prevent it, 40% of the country is still taking their medications 90 days after a heart attack. I mean, what bigger signal do you need? 40%. 60% of people have dropped off their medications after a heart attack. And guess what happens? So we have an effort going on right now where we're using this behavioral health stuff. You might say it's common sense. So we weigh you every day. And we have wireless from the scale that transmits it back to our electronic record. We have a wireless pill bottle. So we can tell whether you opened your pill bottle. Now, if you open the pill bottle and dump them into the trash, then you'll beat us on this. And then we run a little lottery. Every day we run a lottery because we've shown people would much rather win the lottery than just get a payment. So instead of giving you $1 every day to take your pills, we say you have one chance in 100 every day to win the lottery. And people like the chance of winning the lottery. But if you didn't take your pills the day before, as we know from the, then you don't get the $100, and then you have incredible remorse. And people always hate losing $100 more than they like winning $100. So we're using the insights of psychology. You know, people regret the chance. We're hovering over them. We pay their family members to kind of say every day, "Ann, are you taking your pills?" And so we have a buddy system. So the combination of those four things, the wireless technology, the automated hovering, the lottery, and the buddy system, has brought that rate up to about 88%. So 88%, a year and a half out now, of people are taking their pills. And these are very low-cost interventions because we're basically, doing it over smartphones and wireless pill bottles and so forth. And obviously it saves a lot of lives. And this experiment is going on around the country. Two of our doctors that Ann would know, Kevin Vope and David Ash, were funded by the feds to do this. So it's a year and a half in. And it's in Minnesota, it's in Colorado and so forth. So it's an enormous advance. So we're basically showing how you use the insights of psychology and social science to bring it into medicine as a way adhering. We've also have another one I'll mention briefly. How many of you, if you came to our hospital, if we said to you, would you share your Facebook and Twitter feeds with us? How many of you would automatically hand over your Facebook accounts and tweets to us?
What are you doing with it?
Just reading it. Very right. Well, 70%, 70% of people let us read their feeds. And out of that, we're seeing when people stop tweeting, maybe they're depressed and they're not following up on their so we've been able to use their reads here, how much they're texting. We're not like the NSA, we're not meddling in there, we're just looking at big data. But basically, we're showing that with behavioral health and depression and following up and so forth, we're able to predict. When you stop tweeting, when you stop doing your posts, there may be behavioral issues going on, or maybe you lost your job, or therefore your income is going down. So it's been a powerful indicator. We've been running this about 6 or 8 months right now. So this is something everybody has. Everybody has a iPhone, and certainly the generation under 30, they're all tweeting and posting on Facebook and so forth. So using that, so on the one hand, we have genetic analysis. On the other hand, we use Twitter and Facebook as a way of just following up on what you're doing to see whether we can find out what you're all doing. So let me kind of, these are more technical than I need to give you. So I told you earlier about how high hospital utilization is on the East Coast and how we're bringing that down and so forth. Now, one of the things that's also happening in the world is the pharmacies like CVS and Walgreens. If you go there now, you notice they have doctors in there, nurses in there, trying to get into these. They're called retail clinics, and they're trying to come into the space. Some of you who follow some of the management literature over the last 10, 20 years, there's a professor up at Harvard called Clayton Christensen who writes about disruptive innovation. And so the question is, are these retail clinics going to be disruptive innovation that, for example, puts primary care doctors out of business? My forecast is no, they won't. They're very convenient, they're very handy, but by and large, people still go to primary care business doctors. And what I've noticed in the last 40 years in healthcare, every new innovation is one more added thing we do. Nothing kicks anything else out. I remember when I first started running Medicaid in Massachusetts 35 years ago, we built all these nursing homes because a lot of people were stuck in hospitals forever, especially if people became 80, 85 years old. So we built these nursing homes, we get people out of hospitals. Well, we got people out of the hospitals into nursing homes, but then we refilled the hospitals because we had new procedures. And the same thing has happened with everything in medicine so far, is by and large, everything becomes kind of an additive thing. So we'll see how much the retail clinics, you may have noticed just recently, I think CVS paid like $10 billion for another set of clinics. All of us now, I mentioned, are using this. This is probably going to have more powerful effect than anything I've talked about so far in terms of utilization. But you're going to start doing the same thing here that you did to book your restaurants and your airlines and follow your bank account and do Airbnb and Uber and so forth. So we're doing a lot of work right now. One thing I've noticed is, we're a university as well as a medical school, and Wharton is very closely linked to us. 6, 7 years ago, the young doctors who didn't want to be practicing doctors and who wanted to kind of go into finance and so forth were all going into private equity firms in New York. The last 2 years, they're all app developers. Even the private equity guys can't get these people. They're coming out with MBAs, and they're all developing apps. So we in Blue Cross have this national thing going on for innovation, and we fund 10 companies every 6 months, and they're all apps. And these apps are totally transforming healthcare. So for example, we use these apps inside the hospital right now to instantly know, as you know, you go to a complicated place like HOP, you're going to have a pulmonologist, and you're going to have a surgeon, and you're going to have a nurse, and you're going to have a respiratory therapist, and you're going to have a dietitian. And so this way, we can instantly update who all those people are every moment of the day. So you just go to your app and say, who are the 12 people taking care of me at the moment? And you can do it that way. You could, in some ways, think you can do this inside the computer system as well, but this goes so much faster because everybody's carrying this around the hospital and so forth. So we use that, for example, to just make sure who's on the care team, but also to keep track of exactly the resident just came in, or the new medication, bang, go right in there. So we're using these apps all around the hospital right now, and this is going to transform healthcare and quite a bit, especially in terms of how you access. For example, right now, very few counties, like 87 or so counties in Pennsylvania, only about 10 of them have a neurologist, only about 10. So 70-some counties do not have a neurologist. As you know, as we all age and our parents age and so forth, they're going to have cognitive impairment. We have patients coming in from Allentown and Reading and so forth. You imagine, getting mom or grandma into the car, driving down to HOP, navigating the Schuylkill and so forth. It takes a whole day. We now have a tele program in Parkinson's where our doctor, you just Skype in. So no matter where you are, you Skype in. Our doctor's at that end. You don't have to get mom or grandma or dad down from some remote county. Now, obviously, if it's serious, and then we're gonna have to figure out how to see you in person and so forth. But we can do a lot of that. Same thing in teledermatology. As you know, when you go see a dermatologist, what's the first thing they do? They look at you. So when people call up, we say, roll up your sleeve, zap it, and take a picture. We read the eye photo, and we can just say, come on in or not. So we're doing a lot of teledermatology as well. This is transforming the world as you know it, as it has everything else. I mentioned a little bit about the retail clinics expanding enormously. By and large, they're not so dirty secrets. They basically are running these clinics to sell more drugs. CVS makes its money off selling drugs, as does Walgreens, as does Walmart. So that's why they're in that business. And it's going to be much harder. They're not really going to be able to hire doctors. They may have some nurse practitioners stationing it. And increasingly, you may say, well, am I going to local CVS to see a nurse or a doctor? I'll just pick up my iPhone and call them and see if I need a prescription or not. And so this is the rate of growth in electronic health visits, like the two I just mentioned, are expected to grow. This is a little attachment you put on your iPhone. It reads, can read inside your ear canal, and this is happening increasingly. We have one now that can do a little echo of your heart. So it's like a $200 attachment. You plug it into your iPhone, instant EKG, and you save that. So this is. So these are all the kind of things that are happening on the front line. And what's exciting about me and my job, whether it's the ethical issues about end-of-life care, the technology issues of app phones or proton therapy, how to connect the doctors in Lancaster. Lancaster just joined us 10 days ago. So now we're up to one more hospital and $5.5 billion. So we're expanding correctly. But when you look at evidence-based medicine or patient satisfaction, these are the kind of things I get to work on a daily basis, which makes it so exciting to be part of a health system such as ours. I'm going to leave you just a few more quick slides. I use these numbers: 1 in 20, 5 in 50. 1% of the American population incurs 20% of healthcare costs. 5% incurs 50%. If you want to bend the cost curve, one of the big debates in Obamacare, you better figure out how to bend the cost curve on that 5% who spends 50%. Most of us, 50% of the American population does not see a doctor in a year. 100% of zero is still zero. So you don't save any money. Insurance companies love those people because they pay the insurance premiums, and it doesn't cost them anything. And the old proverbial, 30 years ago, there was kind of insurance sign-ups would be up on the third floor walk-up. So anybody, you only want to sign up the people who could walk up 3 floors. You never want to have. But that's called risk selection. But if you know that 5% of your costs are, at 50% of your costs and 5% of the people. You want to avoid those people. That was traditional insurance. Obamacare has changed that. They can't do that anymore. It got rid of what's called you can't exclude people for pre-existing conditions. So right now, places like Penn, we're focusing on that 5%. These are cancer patients, these are heart failure patients, these are preterm babies. That's where all the money is, and we think we can really bend the cost curve on that. And that's one exciting thing we're focused on. And that does not happen in minute clinics, let me tell you that. So these complex episodes, cancer, strokes, we just moved our trauma center from Hupp to Presbyterian about 6 months ago. But those are very expensive cases, and we think there's 20 to 40% savings in managing those cases in a different way. So we're really focused on that. And let me just tell you a little bit about Penn, and then I'll take any questions you have. We have, just like the department retail stores figured out 30 years ago, you couldn't just be downtown, whether in New York or Detroit or Chicago or Philadelphia. You had to go to the suburbs. We went to the suburbs as well. I mentioned earlier that we're across the bridges in Jersey. We're in Bucks. We're in Chester. We're out to Lancaster now. And you'll keep seeing more and more. And what we've done, those these big multi-specialty centers, 100, 200,000 square feet. Very importantly, it has parking, common information systems, but it has primary care as well, specialty care. And increasingly, you'll see surgery center, radiotherapy, chemotherapy in all these places. So big regionalization to where the patients are. We have a common electronic record across, so whether you're first seen in Valley Forge, at Presbyterian, at Pennsylvania Hospital, or out in Lancaster, the IT is right there. This happened in other parts of the world, but we have a common IT. Nobody else has that in our geography. Increasingly focused on taking care of patients over time, so you don't just come to us for the heart attack, but we're going to help you manage your heart failure through a variety of interventions over the next couple of years. That means doctors, nurses, therapists, social workers, all created as part of a team, taking care of people over time. We focus a lot on using information. We compare ourselves on a daily basis to Michigan and Stanford and Methodist and Houston and Mass General and Hopkins. Constant comparison database, best practice, benchmarking at all times. And we've taken these initiatives to focus on new payment models. As I mentioned, we now in orthopedics and in cardiac, we have bundles where we get paid for 90 days rather than just a hospitalization, and we take that risk. So to kind of, hopefully what I've told you today is there's a lot going on nationally as a result of Obamacare, and we'll continue, and I assume that even if Republican wins the presidential election next year, Obamacare is here to stay. It's just too entrenched. And one of these days, some of those states that have not expanded Medicaid will do that as well. Big shift to outpatient care. More patients are insured, but more higher out-of-pocket costs. Again, the jargon for that is called consumer-directed health care, but just means you're paying more. Value-based care is the phrase for we get paid and evaluated on whether we prevent infections. Hopefully all the doctors you see wash their hands before they see you. We really focus on that. I point out to you Philadelphia is overbedded, so if you're Comcast or Blue Cross, you say, I've got to get to Sacramento rates. I can't keep running that much higher. There's whether CVS expanding our market, Blue Cross has a big primary care group that they've brought into this market as well, trying to really change more to a Kaiser kind of model. So just a lot of change in the market. Fortunately for us, we're doing very well. We every year we're the only ones listed the best hospitals in America, that U.S. News competitive ranking, we're listed there. Financially, we're very solid. Ann's on our Presbyterian board. We've done incredibly well in recent years. And we've been able to invest in infrastructure, these new major outpatient facilities everywhere. And this, as you know, any business you're in, these IT investments are enormously expensive. And one thing I'm very proud of, we train everybody. And one of the reasons, if those who have experienced Penn Medicine in recent years, everybody's trained. The people who push the wheelchair, the people who register you, the doctors. We've trained in the last 18 months over 6,100 doctors and nurses and the new ways of patient care. So we do an extensive amount of training. In fact, right across the street, the old Comcast building there at the Center Square, we have a good chunk of that, and our training center is right across the street. And in fact, I'm down here a lot because I teach some of those training classes. So I'm enormously proud. The front line of our Penn Medicine now has a uniform way of presenting ourselves, whether you're in Valley Forge, at Hupp, and so forth. So thanks for inviting me. I'd be glad to take any questions.